Hi, everybody, and welcome to what we're calling our live forum event, and we'll explain what that means here at the TCOYD office. So I am Dr. Jeremy Pettis. I'm an endocrinologist, University of California, San Diego. Been living with type 1 diabetes since I was 15, and I'm joined by my good friend and colleague,
Dr. Steve Edelman, and ditto with the rest of that stuff.
Yep, also diagnosed when he was 15, also an endocrinologist. So what is this event? Well, we're really going to be giving you a behind-the-scenes look at what happened at this year's American Diabetes Association meeting, the ADA for short, because that's a mouthful. So what is the ADA conference? Well, it's the kind of bee's knees, the biggest deal in diabetes conferences, really, I would say, in the world. But it happens here in the United States every year, and it rotates around where it occurs. And this year, it just so happened to happen here in San Diego, California, at the end of June, so just a couple weeks ago.
Yep.
And this is really where the kind of the hottest, latest information of diabetes is released, and not just diabetes, but on the heart health and kidney health and all these kinds of things. And every year for the last, I think, 17 years at this conference, TCOYD has put on an event with diaTribe that we call the Forum. So tell us what that is, Steve.
Yeah, basically what we do is it's a fundraiser for both of our organizations to promote our mission of educating people and healthcare professionals about diabetes. But what we do is we have it at the very last night. We pick 5 of the panelists, which are the most highest level experts in their area. We try to balance it off. Some are type 2 folks, some are type 1 folks, and some go both ways. And it's an hour-long session, and Kelly Close and I work on the questions of the hottest topics of the meeting. And I just want to add, this meeting is the most important diabetes meeting of the year, and they call it the American Diabetes Association Scientific Sessions. So it's important for all of you to know that in the forum, face-to-face in San Diego, there are all healthcare professionals, but a lot of researchers, clinicians, people that work for the diabetes pharma and device industry. So they're all pretty much up to snuff with all the verbiage. You're going to hear a lot of alphabet soup if you were there live. And what Jeremy and I are going to try to do is to not dummy it down by any means, but try to avoid some of the acronyms that you may have a hard time following, which is what happened last year. And so we want to convert what we learned at the forum on today's live.
Absolutely. So the idea is we give you a window into this conference, but then we kind of break it down into what it means in lay terms. And we know that you all watching are absolute geniuses, but just help, like, what does this all mean?
And we're going to try to we're going to summarize these hot topics to give you the most important points about each one.
Yeah. And we can't go on any farther without mentioning our sponsors that helped, put this event on. And so through the help of the sponsors is actually putting on the event, there was food, drinks, things like that. But then the proceeds go to diaTribe and TCOYD to promote education for, you guys and people living with diabetes. So thank you to all of our sponsors. I should also mention that there is a Q&A. So we're going to go through, kind of our program here, but you can enter questions in whatever platform you're watching. We'll filter through those and get to whatever questions we can at the end. If you have something that pertains to one of the topics that we're talking about.
Should we mention one at all?
Sure.
Yeah, well, to let all of you folks with type 1 know that we are putting on our very first face-to-face event since 2020. And it is for people with type 1 diabetes. It's in San Diego. It's called the Ultimate Conference and Retreat for people with type 1 diabetes. You can read about it and sign up on our website. It's just an awesome weekend to hang out with all your brethren with type 1 diabetes, including our faculty who are endocrinologists with type 1. Mm-hmm. And Jeremy and Eric can be playing live, and we're going to have a Beatles band there. Mm-hmm. It's going to be awesome.
So the way that this is going to work is that we're going to set up a topic. And then we're going to actually show you a clip of what occurred at the forum of one of the kind of medical professionals talking about it. So you're going to get our breakdown, you're going to get actually what happened live. So again, you get kind of the best of both worlds.
And we're dressed up at the forum.
Yeah, so you might not recognize
He's got a sports coat on.
I know,
for
crying out loud. That thing
God.
was itchy.
And I'm wearing a tie.
Yeah.
I still got rope burns.
All right, so these are not really in any particular order, but the first topic was essentially what's going on in the world of weight loss medications in obesity and diabetes and all those kinds of things. So we've talked a lot here at TCOYD and obviously through diaTribe and different things going on in this field. We have Ozempic, that you can't pick up a newspaper or go online without hearing about celebrities and things like that, people losing weight, a medication called Wegovy, and then most recently, a medication called
Mounjaro.
that's how you have to say it with the Italian accent. It's a once a week injection that really helps people lower their blood sugars. So it's been approved for people with type 2 diabetes to improve their blood sugars. But now there's a lot of data coming out that they've tested it specifically in obesity, so people with or without diabetes. And this was one of the hot topics at the ADA of what are the results of some of these studies for Mounjaro in people with obesity.
Yeah, and I can explain a very complex topic quickly. Ozempic is a GLP-1 receptor agonist, and Mounjaro contains that as well, plus another agonist. So it's called a double agonist. And things we're not going to talk about, which are further down the line before approval, are triple agonists. And they all seem to want to outdo each other in glucose control and weight loss. But Mounjaro was one of the hottest topics at the meeting.
So one of our panelists was a guy named Dr. Juan Frias, a good friend of us here at TCOYD, and specifically of Steve, because guess what? Steve trained Juan. He was one of his trainees, so he definitely knows what he was talking about. And Juan, no guff, has really been the guy that's been in the know about these medications. Yep. So let's hear what he had to say specifically about what they call the SURMOUNT studies, which is these studies looking at Ozempic in people with obesity.
SURMOUNT-2 is a study looking at tirzepatide specifically for overweight and obesity. So it was in patients with type 2 diabetes. And we had done the SURPASS trials, which were diabetes trials with secondary endpoints of weight loss. And in those studies, there was a dose-dependent reduction in body weight, and actually got probably the highest, or did get the highest body weight reduction that we'd seen in diabetes to that point, somewhere in the between 12 and 14% weight reduction at either 40 or 52 weeks. But for the SURMOUNT program and for regulatory approval, specifically for overweight and obesity, there has to be a pivotal trial in patients with type 2 diabetes, and it has to have at least 52 weeks after the dose has been escalated to the maximal dose. So this was a longer study. It was 72 weeks. It included calorie deficit diet, 500 calorie deficit diet daily, lifestyle intervention, and the primary endpoint was reduction in body weight, and actually saw greater reduction in body weight than in the SURPASS trials, not by much actually, which was interesting, which goes to show that with a drug this potent, maybe the lifestyle intervention, although it is very important for other reasons, may not be as important for weight reduction, but basically saw about 15% weight reduction, and very, very importantly, I think, the reduction in A1C, which was a secondary endpoint, but you're reaching now levels where 50 or so percent of patients are having greater than or equal to 15% weight loss. So clearly important, not just for dysglycemia, but for all the complications of obesity. And you're getting, in this particular study, over 50% of the patients achieved a hemoglobin A1C of less than 5.7%.
So first of all, there you can see what this forum actually looked like. There was the 5 panelists there in the middle. We had the moderators, Steve and Kelly, on either side, and just this whole discussion that was going on in over an hour. So Steve, tell us, what did Juan just say?
Yeah, what I wanted to tell you is that when you can lose 18% of your body weight, let me just put that into context. Let's say you volunteered for the study to be on Mounjaro, and it takes quite a while to reach the maximum dose because you got to start low and titrate the dose. If you weighed 200 pounds when you entered the study, those folks lost on average 36 pounds. That's a lot when you think about it. And that's not just the best case scenario. Now, the other thing that is so amazing is that they reported the number of individuals that ended up with an A1C below 5.7. Now, we've never seen that before because the goal for diabetes is less than 7, and non-diabetic individuals are less than 5.7. So some of the SURMOUNT studies are looking at also at treating pre-diabetes. So
well, I was just going to say, to put
shocking.
that in context, when we're saying getting people below 5.7, that's saying, not just like good enough, less than 7.7, less than 7, it's completely normalizing metabolism. So people are going essentially into the non-diabetic range.
That's amazing. And there were just a lot of studies at the American Diabetes Association meeting about different GLP-1s, different combinations, but the SURMOUNT-2 was the one that got the most attention.
Yeah. And I would say if you're a type 1 listening out there, when these things get approved for obesity, that can help, because for type 1s, guess what? 2/3 of type 1s are either overweight or obese. And the hope is with Mounjaro that it would be approved for obesity, and that opens the door for us type 1s to be able to potentially use it specifically for weight loss. Now, to qualify for these drugs, you technically have to be in the obese category usually, but it hasn't been approved yet. But anyways, there's such a buzz about these compounds because the weight loss is incredible. And to be honest, the weight loss drugs we've had up until this point before Ozempic are just garbage. And these are actually very, very good weight loss medications.
Yeah, we should mention at least Trulicity, which is another very good GLP-1. Lilly, who makes Trulicity, now makes it in higher doses. So the weight loss is dose related.
Yeah.
And the other thing is, that you mentioned it on our podcast that we did. When a company gets a drug approved for obesity, they somehow are obliged by the FDA to change the name or a new name. It's the same exact stuff in higher dose.
Right.
Ozempic, Wegovy, Victoza, and Saxenda. So, and then there will be Mounjaro, and what do you think the weight loss name is going to be?
Mounjaro. We don't know yet.
We don't know yet.
All right, so switching gears to more of a type 1 topic. So I don't know if you guys could see from that initial clip there, but right in the middle was an extremely handsome individual.
He's apparently one of the world's expert in type 1 diabetes. That's why we asked him to be at the forum. Let's see what he has to say.
So specifically, we asked him, what's going on in the world of preventing, kind of treating type 1 diabetes. So much going on in this area. So I can't say it better than this guy.
You
so
can't.
Let's just listen to what he had to say. We have teplizumab. The first approved drug in November to modulate the course of the disease. And it doesn't matter how much you know about it or what you think about screening for type 1 diabetes, just pausing and thinking that we, for the first time, have a drug that addresses the underlying condition of type 1 diabetes. So a theme in the meeting has been, oh yeah, type 1 diabetes is an autoimmune disease. What the heck is a T cell? These things that we haven't been thinking about for a long time because we've been focusing on glycemic control. So again, we have now teplizumab, which is approved now to delay the progression of type 1 diabetes from stage 2 to stage 3. And I think just there's still all this discussion about what these stages are. But I think the good news is you couldn't walk around the conference and not hear people or see people showing pictures of what is stage 1, stage 2, stage 3. What are these autoantibodies? How do we screen for them? Who is an appropriate candidate for this drug? I think it's been so good to now have this final approval, but it's also shown how woefully unprepared we are for screening people for this, for finding people, for infusing this drug. I'm an endocrinologist. I've never stepped foot in an infusion center. None of us have really done these autoimmune, therapies. So this is all good news, but it's time for us to kind of ramp up.
Jeremy, I don't think you can beat what he just said, but go ahead and make a comment.
Yeah. So what was I saying there? So what are these different stages of diabetes? Well, I don't have to go into too many details, but the point is that we now have the ability to draw somebody's blood and check these antibodies and determine if somebody's at risk for developing type 1 diabetes. And we're really focusing initially on first degree relatives of people that have type 1. So that would be like our kids, our brothers and sisters, our parents. And if they have these antibodies, their risk of getting type 1 in the next 5 years or so is about 50% or more. So that's a good sign that this autoimmune process is happening. And there's a drug now called teplizumab or Tzield that can be given to people who are at risk of developing type 1, and it's been shown to delay the onset by about 3 years. Now, you can make your different interpretation of how meaningful that is, but to me, 3 years is fantastic. 3 days is a big deal. And that's the difference of a kid being 8 years old versus 11 years old. There's so much going on.
Also being prepared for the potential, but not 100% for sure diagnosis. You don't have to go to the diabetic ketoacidosis, and look at how fast all these advances are ramping up in the last couple of years. So I think it's a tremendous advantage, and this medication is now being studied, and we should hear about the results soon, for people with stage 3. That's just people who come down with new onset type 1. Now, I should say one more thing that's really important, is that people in stage 2, there's no symptoms. And you mentioned screening first-degree relatives and maybe even second-degree relatives. And that's the important message I want to send out right now, that all of you with type 1, you already got type 1 diabetes, but you should really talk to your first and second-degree relatives and see if they want to get tested. It's a simple blood test, or you can do it with a drop of blood. I think we have information on our website.
Yeah, you go to type1tested.com, and it's the number 1. And they can actually send you a kit to do at home, with a finger prick, and it can tell you if you have these antibodies positive or not. And if you do, going to an endocrinologist and talking about potentially starting this drug. But again, the point that I was really driving home there is this is the first time ever we've had a drug that does anything to the underlying disease. We have great CGMs and pumps and these things that control blood sugars, but gosh, could we just think about preventing or even curing the disease at some point? And that was something good to hear people talking about.
I haven't seen him this excited in years. And you know what? Up until the approval of this drug, they have cured laboratory animals 300 times. Rabbits,
with 300
mice.
drugs, yeah.
Yeah, with different drugs. And the headlines come out, even at the ADA meetings, potential cure or treatment for type 1, and none of them worked when they brought them to human studies. And that's important because we are not a bunch of rats or mice or rabbits. And we have a different immune system. And there are people that used to stand up at meetings and scream, no more research dollars wasted on laboratory animals in the area of type 1. That was Jay Schuyler. So this is a big deal, and it opens the door for other companies, other compounds that can affect the immune system in a positive way.
Yeah. All right, so moving on to the next topic, which is one that's slightly controversial, or people have kind of different thinking about how kind of impactful this is going to be. And this is what we call once weekly basal insulins. So if you're out there and you take a basal insulin or a long-acting insulin, they're always once a day. That could be Lantus, Toujeo, Tresiba, and these work to give you your kind of background basal insulin. So companies now, namely 2 of them, are working on developing and doing clinical trials now in once a week basal insulin. And so the positives are, yes, that's less injections, 1 injection a week versus 7. Some of the concerns are that you have to do like a weekly dose. So if you were on, 20 units a day, that'd be 140 units a week. This seems like a big dose to give once a week. What if you, get sick? All these kinds of things. But the clinical trials are ongoing. They've been successful. These drugs are going to come to market, I would say. So let's hear first what our good friend Athena Samikas has to say about it, and then we'll get Steve's commentary. So real quick, Athena also works here in town as an endocrinologist, another trainee of our great Dr. Edelman's. So she absolutely knows what she's talking about. And I think Juan chimed in on this one too.
That's right, that's right.
So let's hear what Athena and Juan have to say about this.
Both the type 1 and the type 2 studies with icodec, we're in the middle of doing them now with the Lilly product, BIF, and our patients love them. I have to say that was a uniform response. Maybe not so much in the type 1. That it got a little bit more complicated with the type 1 population. But overall, having just 1 injection a week they were thrilled.
What I would say was actually surprising. I mean, as we've advanced from, MPH to glargine to U300, so on and so forth, it's always been sort of similar A1C. But if you look across the 5 icodec studies, there's actually, 1, 3, 5 significantly greater A1C reduction with icodec compared to either insulin glargine or degludec. So you have to take, obviously, the glucose lowering as you interpret the hypoglycemia, and a lot of CGM done in those studies, which I think has been nice.
So both Lilly and Novo Nordisk, the scientists there, figured out a way to make the insulin given once weekly. So in clinical trials, as you mentioned, and Athena mentioned, people loved it, it worked well, did not have more hypoglycemia, brought the A1C down nicely, and they compared it to degludec and glargine, and it was equally effective. And so that's important. In the type 2 space, it might make a big impact, especially for people who have a hard time remembering to take their insulin. I think you mentioned on our podcast that for type 1s who forget to take their insulin, end up in a pretty serious state called ketoacidosis, it might be helpful for them. But in a nutshell, we'll see how it comes out, see how it works in the open market. And you've already mentioned that it's not so much that you're taking a ton more insulin, but the doses are foreign.
Yeah.
But they are, the way they're written, are much higher. And you have to use a calculator to figure out the titration schedule. And it takes 4 to 5 weeks to reach equilibration. But saying all that, all we need is education to the people that may use it and to the healthcare providers that may prescribe it.
Yeah, so why did I say this is controversial in the beginning?
Yeah.
It's because I think there's certain people that think that this is going to be the next blockbuster drug. Everybody with diabetes is going to be on it. And other people that have some reservations with, how do we titrate it and things like that, so we'll see. I think everybody, though, agrees that it's really not for the kind of type 1s. Actually, in the clinical trials, the type 1s did have more hypos, so there is some downside. But like you mentioned, it might be for the people that are forgetting doses, things like that. So, interesting topic, yeah.
Yeah, last thing I'll say is, what excites me is the potential of putting a weekly basal insulin together with a weekly GLP-1 receptor agonist. And we know that Soliqua is a combination of, basal insulin plus their lixisenatide, and Zoltify is Novo's combined GLP-1 basal insulin product, but those are once a day.
Yeah.
And we know they work well in the type 2 space. And lastly, I'll say, this might be too much information, but the FDA did require both Lilly and Novo to do the studies in type 1s. And I think you're right, there might be a subset of people that would really benefit from it.
Yeah, and just to be specific, we were talking a lot about Ozempic and Mounjaro, and the idea is, well, what if you take an Ozempic and you combine it with a once weekly injection? You got one kind of supercharged injection there.
Yeah.
And the blood sugar lowering there would be, we can only imagine, like super impressive.
Yep.
So there's some, more to come in that topic. All right, so moving on, we're switching gears a bit. And because I said in the beginning that this is a diabetes conference, but diabetes touches multiple different organ systems, we can't forget about the heart, the kidneys, cholesterol, all that. So this next topic is really about cholesterol and new guidelines that we have in terms of how aggressive we should be with our targets for specifically what we call LDL. So when you get your cholesterol panel measured, there's usually multiple components. There's total cholesterol, LDL, HDL, and your triglycerides. And if I had to pick one to be the most important, it would be the LDL, or we think of it L as lousy, where that's the one that really can increase your risk of cardiovascular disease. So we want that to essentially be as low as possible. And we previously had goals that anything under 100 was good, and then we thought maybe we don't need targets at all. But just recently, the ADA has new guidelines on what these targets should be, and we asked your friend Athena again what she thought about these. So we'll hear her comment, and then we'll give you our take.
And one of the things that I went to today that I thought was good, it started out the ADA standards of care for LDL. And this year they changed. And the group that went over what the updated standards were emphasized that LDL for primary prevention of heart disease, the targets are now less than 70 if you're between the ages of 40 and 75. And for me, where I worked in a lipid clinic for many years, I'm so glad to finally see that they are back to the targets. For secondary prevention, they've pushed those numbers down to 55 milligrams per deciliter, really going after trying to prevent heart disease in those that have diabetes. So I thought that was important.
All right, so there you heard it, and to really just put a nail on this, that in general, everybody with diabetes should have an LDL at least less than 70. And if you're at a higher risk of cardiovascular disease, namely you've already had a heart attack or some heart issue, you should be super aggressive and less than 55. Now, the way that I think about this is that if you're not taking cholesterol medication, there's no way your LDL is going to be less than 70. It just doesn't really happen kind of naturally. I don't care what you're eating, drinking, how much you're exercising. So I think a simpler way of putting this is if you have diabetes, you need to be on something to address your cholesterol. Usually this is a statin, but there are other medications. And so this is kind of a big deal that we need to be extremely aggressive with our cholesterol.
Yeah, and we providers, all of us providers, one vein in our existence is to start medications for cholesterol level in people. They just want to push back. They've read all these things in Reader's Digest about statins, how they'll kill you. And it's so important because the number one cause of death in any type of person, any person with any type of diabetes is
Cardiovascular disease.
yeah, and so this is something that it's a silent killer. I hate to get all morbid on the show here, but it's so important. And you mentioned that we do have lots of different drugs. So if you can't tolerate a statin, Jeremy and I both take a medication that's in the class of PCSK9 inhibitors. There's a new class called Nexletol. So there are more choices now. And the reason why we put this as one of the highlights, because it'll make a huge impact, especially for all of you out there living with diabetes.
Yeah, and notice that I didn't say, depending on what your A1C is. So I don't care if your A1C is 6 or 6.5, you're in good, glycemic control, you still need to be addressing your cholesterol. Because when it comes to heart disease, it goes in this order. Number one, the most important thing is what your cholesterol is. Number two is your blood pressure. And then a distant third is actually your glucose control. So if you're ignoring your cholesterol and your blood pressure, you're still at a very high risk of cardiovascular disease. Now, glycemic control really matters for the eyes and the kidneys and the feet. So good job getting your A1C to 6 or 6.5. That's protecting those organs, but it's not as helpful when it comes to the heart.
Yeah, and it turns out that these new guidelines are based on hard, very good data. The American Diabetes Association doesn't come out with guidelines unless there's solid evidence behind it. And you talked about LDL being the worst, and some people may say, well, the HDL is protective, you want to get that high, but here's the issue. We don't have any drugs that will just raise the HDL, but we do have medications that lower the LDL. And your doctor will talk about the LDL to HDL ratio perhaps, but you need to have a good discussion. Are your cholesterol levels at the level where you want to prevent the development of heart disease? And if you've already got heart disease, you got to get super aggressive.
Yeah. And us endocrinologists, the last thing I'll say on this topic, we are trained in addressing blood pressure and cholesterol. So don't spend 100% of your appointment talking about your blood sugars and then forget about these things, assuming that somebody else will kind of pick it up, because a lot of times it falls through the cracks for that reason, because nobody's sure who's kind of taking care of it.
Yep.
So you need to advocate for yourself. What's my goal? Where am I at? All those kinds of things.
You need to take control of your diabetes.
Yeah, TCOYD. I don't know which way it
See
goes.
that right
there
here?
we go. Okay. All right, shifting gears again. So we talked about kind of the heart, I suppose, LDL cholesterol. So what about the kidneys? So similar to what's going on like heart movements and new biomarkers, we're now getting more aggressive with how we're measuring kidney function in people with diabetes. And the good news is that we're doing this because we have such great drugs now to help people prevent kidney disease, namely the SGLT2 inhibitors like Farxiga and Jardiance. These are once-a-day pills that have shown to have tremendous benefits, particularly for people with diabetes, in preventing or halting kidney disease. So to talk about this, we had another good friend of TCOYD and diaTribe, Dr. Eugene Wright, kind of address this topic.
As I mentioned earlier, one of the things that I thought was very impactful at the conference is that there's a lot of movement both in the U.S. and abroad to start to do the UACR and the EGFR routinely according to the guidelines, and people are getting the word about that. It's in the NCQA HEDIS criteria. I understand it's being considered for MIPS, so there'll be some additional or incremental reimbursement for doing that.
Don't worry.
Okay, so we're back. So, really the issue there is that there's multiple ways to measure kidney function. And we're getting kind of more thoughtful about, in addition to kind of some routine blood work, everybody needs to be basically looking at their urine. So bottom line is, if you're living with diabetes, your doctor should be ordering a urine test, and specifically it's how much protein you have in your urine, and you don't need to really write that down necessarily, but just know that at least once a year you should be peeing into a cup, and your doctor should be looking at that information for how your kidney function is. And if you have any kind kidney dysfunction, this is when you absolutely need to be on these SGLT2 inhibitor medications, like Farxiga and Jardiance, that not only help, reduce your blood sugars or, make your blood sugars better, they help with kidney function, they help with heart failure. Anything you want to say about these drugs?
You know what? There was one class of medications approved like over 25 years ago to help prevent the progression of diabetic kidney disease. These were what we call ACE inhibitors and ARBs, and that's things like Monopril. And they were kind of weak at doing that, but they did show that. But the SGLT2s, as you mentioned, Farxiga, Jardiance, they are very strong in terms of preventing the progression, and they have the official approval by the FDA to say that on the actual label. So think about this, the drug lowers glucose, it helps people lose a little bit of weight, prevents congestive heart failure, another serious and common abnormality in people with type 2 diabetes, and delay the progression of diabetic kidney disease. So, and there are other medications that also work on delaying the prevention of diabetic kidney disease. The one that's made by Bayer Pharmaceuticals, and that's the mineral corticoid.
Corindia, yeah.
Thank you. I forgot temporarily. Corindia is another drug approved for that specific indication. So when you look at all these programs they have for doctors put on by Medscape and other education companies, some of those experts, those kidney experts say throw the whole book at people to do because you can take them together.
Yeah.
ACE inhibitor, SGLT2 inhibitor, and a drug like Corindia.
Yeah.
And so it's important for all of you to know. And just lastly, you got to make sure, as someone living with diabetes, you get the urine albumin to creatinine ratio. And you look at the eGFR, glomerular filtration rate, which is on a typical chem panel, and the urine albumin to creatinine ratio can be calculated from a urine test plus the creatinine level, which is on the chem panel. But you have to, as a doctor, you need to order that ratio.
Yeah.
So it's important for you to remind, in a nice way, that's a test that will tell you the structural function and damage of the kidney.
Yeah, and that can be complicated for people. But the good thing is these are common tests, and if they're abnormal, they will be flagged. So they don't need to know like the exact numbers it should be. It's just, hey doc, are we looking at my kidney function like appropriately? I think we get them in the right place. And again, these medications are just, I think we would agree, they're not utilized enough. And they've shown such good results that we need to use them more.
And that's why we're making a big deal of this at the forum, because not enough healthcare professionals are screening appropriately. And our motto at Taking Control of Your Diabetes and diaTribe is that if you're someone living with diabetes, you just need to be up on the latest and have a good discussion with your healthcare professional to get the care you need.
All right. I think this is our last topic. So we're switching back to type 1s. And this was, the category of basically what other therapies do we have for type 1s or that we're working on that are not insulin? So we always need type 1s as somebody, we always need insulin as people living with diabetes at type 1s. But are there other drugs that we can use to address these things like weight, blood sugars, cardiovascular disease, kidney disease? I'm kind of tired of us missing out was my plea here of everything that we just mentioned. All these drugs, they're not approved for people with type 1. So where are we in the world of what we call adjunctive therapies in type 1 diabetes? And I'm just going to let myself take it away and run with this.
Go for it, bud.
When it comes to adjunctive therapy for type 1s, I think the main problem is that we need to recognize that this is a need in type 1s. The paradigm in type 2s has always been combination therapy and the Amonest octet, and we address these multiple metabolic pathways that Ralph DeFranzo taught us. He had his glass of wine and he left though. But the same thing exists in type 1 diabetes. Yes, there's insulin deficiency, but the alpha cell is messed up. There's insulin resistance, there's GLP-1 issues. And ultimately, we need to kind of adopt a similar approach that we have at type 2 and type 1, and we haven't done that yet. And there's, like I said earlier, universal insulin resistance, there's weight gain, there's cardiovascular disease, there's hypoglycemia. These things are actually made worse by insulin. So in the event that you develop the perfect AID system, which I hope we do, and I think glucose control is a solvable problem, you're still left with all these other issues that we're dealing with in type 2. We're talking about heart disease and kidney disease,
But where is it in type 1? What about the type 1 that has chronic kidney disease and we can't use SGLT2s in them? What about the type 1 that's overweight and obese, which is, by the way, most of us, we can't use GLP-1s in them? It's just, it's wrong.
It is wrong.
Well, Steve was saying I was whining, but no, I think I was an impassioned plea that I think there's this sometimes inappropriate differences between type 2s and type 1s. People think type 2s need all these things. We have to talk about heart disease and weight, and type 1s are all, it's just blood sugar and it's just insulin. And that is a dramatically oversimplified kind of thinking when it comes to type 1 diabetes. The type 1s have increased cardiovascular risk. We deal with hypoglycemia, all these things that other people with diabetes deal with. So thanks for listening to me, quote unquote, whine with that. So I think that wraps up kind of the official program, and we're gonna get into the Q&A part. So I hope, again, our goal there was to give you a behind the scenes, what goes on this conference, the type of discussions that we're having, the type of questions that people are asking. And when we kind of distill it down, hopefully it makes sense to you. And it's just, we're all kind of having the same conversations. We might be using different language and doctor speak and these kinds of things, but it's all kind of the same issues of how are we improving care for people with diabetes, with technology, with medications, access to care. And it was exciting for us to be there because this was the first conference for me kind of post-COVID that felt the most normal. Being back with colleagues that it's cool to see their passion and things for diabetes research. It's cool to learn about things that you don't see every day. I don't talk about LDL and I don't talk about kidney disease. So hearing from these experts about what these new goals are, so I can bring that back to my patients. We can share with you, so you can bring it to your doctors and kind of create this circle of learning that occurs, thanks to these events.
Yeah, you mentioned access. There was quite a bit of discussion about the social determinants of health. And, we just have to think about the barriers people have to getting to the best providers, getting the best medications, the best technology, getting the things we're talking about at this meeting, and everything from, does the individual have enough food to eat? I mean, at the one end of the spectrum, or transportation. So it's something that raised the awareness at the meeting as well, and that was, I think, very important to do.
All right, so some good questions, and I'm going to rapid fire through some of these. These are very good questions.
Hey, give me a chance.
So first, when will there be a cure for type 1 diabetes? Well, guess what? We don't know. So the mantra has always been 10 to 15 years. It's always been right around the corner. Steve was diagnosed in the 70s. They told him 10 to 15 years. Mm-hmm. I was diagnosed in the 90s. They told me 10 to 15 years. Yeah. Right now, I don't know.
10 to 15 years. I think that's really more accurate. Yeah. With drugs like TZIELD, other companies like Vertex and Dompay, you know what? We're closer now to finding either an extremely good therapy that you can give early that preserves the beta cells or a cure. So in the meantime, take control of your diabetes.
Mm-hmm. All right, so what are the side effects of TZIELD? Well, first of all, it's a 14-day IV infusion. So you come in every day, you get the infusion that takes 30 minutes to an hour, and you go home, but you have to do that every day for 14 days, and it's a one-time kind of course. The side effects are that it can temporarily decrease your white blood cell count, but it's transient, and it comes back to normal after about 2 weeks or so. So people can get a little nausea, a little kind of cold, flu-like symptoms, but generally speaking, it's very well tolerated, especially in my mind if the trade-off is delaying the disease by a number of years. So what about some of these cell therapies like Sema or Vertex therapies for type 1 diabetes? This is a great question. So these are companies that are working on, for folks like us that have had type 1 diabetes for a while, there's no beta cells that are there to save anymore. We're not trying to prevent type 1. We're just trying to control our blood sugars. And these companies like Vertex now have developed stem cells that they can make essentially into beta cells. And that's important because that means there's a renewable, ongoing source of cells that we can use instead of what we used to do was relying on donors, organ donors, and there's only so many of those to go around. So at least we've solved the problem of making these cells, and now it's all about how do we give them back to people with type 1 diabetes. And there's really two main ways that they're doing this. One is just taking the cells themselves and infusing them to actually go into your liver, and that actually seems to be working really well. except people have to go on immunosuppressive therapy, drugs to dampen the immune system, and that's not something you want to do unless you really kind of have to. So the second way they're working on it is actually putting these into devices and encapsulating them and actually putting them in under the skin to see if they can do that without needing immunosuppression. So this is moving forward, but it's still a long ways off from kind of from it's in clinical trials, but in terms of use for the masses.
Yeah, and they use this technology called CRISPR. It's not to make your celery, crisper, but it's a technology to use on top of these beta cells that you put in any way to make them not recognizable by your own immune system, so that you don't have to take immunosuppressants. So, they're advancing in this area, rapidly. So I'd say 10 to 15 years.
All right, should our relatives over 30 be tested for autoantibodies for type 1 diabetes?
Yeah.
Absolutely. So you can develop type 1 diabetes at any age. And actually now there's data, lots of data showing that half of people get type 1 diabetes as adults and half as kids. And we used to kind of think that everybody was kids. You had a 90-year-old that was diagnosed with type 1 diabetes.
Yep.
So if they've never been screened, absolutely. In terms of the times, like most commonly that people get it, there is a bump, when kids are 4 or 5, when they first go to school, we think and exposed to viruses and things like that. And again, around the age of 11 or so. So those are times that we really kind of highlight. But really, if somebody's never been screened, any age, absolutely.
Yeah, I should mention that, we talked about screening first-degree relatives, second-degree relatives. It turns out that 80% of the people that come down with type 1 do not have a family history. And some organizations, ISPAD is one of them, that recommend screening of the general population. But right now, these infusion centers are being set up, and they're focusing in on the low-hanging fruit, which is first and second-degree relatives.
So why are there no weight loss meds for type 1s? We have insulin resistance too. That was kind of my whole pitch. That essentially, more or less, these just haven't been studied, and there hasn't been official approvals for them. But again, if we get these drugs approved for obesity, that can be kind of a workaround, because if a type 1 has obesity, they could potentially go on it.
Can I say one quick thing is that when a drug company that makes these products, they have to do a large series of studies, present it to the FDA. They can't just put type 1 and type 2 together in the same study. So it's a difficult endeavor. And I would say this, the SGLT2s that we talked about, preventing the progression of kidney disease, we know that they work well in people with type 1 diabetes. And these companies went to the FDA a number of years ago. You and I were both there. And the FDA turned it down because there was a small rate of ketoacidosis, even though there could be some very good mitigation plans. But here's the thing. I think that if these companies went back today with all the benefits we know now about kidney disease, heart failure, these drugs would be approved with certain stipulations, And but they were ahead of their time a little bit.
Yeah.
They just didn't know all the other benefits in type 1. And lastly, I'll say that you and I prescribe SGLT2s and GLP-1s, like Ozempic, for people with type 1 diabetes. And just because it doesn't have the official indication, it doesn't mean that we cannot prescribe it and use it if us providers feel it's safe and effective for any individual. So that's important. And if you think it might help you, talk to your healthcare provider. If he says no, just call our office at UCSD. We'll try to make room for you.
All right, we got a couple minutes left and a number of questions. So
Okay.
I really want to do a rapid fire
Okay, go for it.
round here. So with Mounjaro and other weight loss drugs, does the weight come back after you stop? In general, yes. When you stop these medications, the effects go away, people start to eat more and tend to gain the weight back.
Okay, but if you take the extra effort to really change what you eat, how much you exercise, you could blunt that weight gain back.
Absolutely. Can you explain the differences in type 1 antibodies? My GAD is 0, but my insulin antibody was positive. So generally we check 4 autoantibodies, and you don't need to know the names of them. But we really get concerned when at least 2 of these are positive. So you should check all 4 and ask your provider what they are, or if you do the type1tested.com, they will check all 4. And if they come back and 2 of these or more are positive, you don't have to worry about the number of what it is. That's when you need to go see, a medical provider. Does insulin cause weight gain?
It can cause weight gain. Yes, it does. And sometimes you can't get around that. But what we do in clinic, real quickly, is to, especially for type 2s, use the least amount of insulin that's required to get your desirable glycemic control. Us type 1s, we need insulin, and if we take too much, we get low, and then we back off. So it's pretty straightforward.
Yeah. So are the updated LDL levels for both type 1 and type 2? So generally, these are for type 2. And so the question might be, well, what if you have an 18-year-old with type 1? Is their LDL goal still less than 70? And we don't really have the data there for type 1s. Generally, in clinic, I use just when people are over 40, but I think the guidelines are less clear in type 1.
For me, I'm treating people earlier. It's important. Heart disease starts at a young age. Even in those poor gentlemen that died in the Vietnam War, when they did autopsies, they saw tons of plaque. So I would say they pertain to type 1s, and you got to treat as early as they are abnormal. If you're 17 years old and you had a lot of people in your family that died of heart disease at a young age, I wouldn't wait.
Okay. I'm already on statin. How do I know if my dose is correct? Well, you should get your LDL checked. And if it's still, not at goal, typically less than 70, then you might need to increase the dose and or add another medication. Are SGLT2s appropriate with prediabetes, but decreased EGFR? So basically, you don't have diabetes, but maybe you have some kidney disease. So yes, these medications now are indicated for people with kidney issues and heart failure issues, period, whether you have diabetes or not. So if for this particular person you have prediabetes, so you might not be taking it for blood sugars, but absolutely taking it for your kidneys.
Agree.
What are the names of the kidney meds again? So the common trade names are Farxiga, Farxiga, and Jardiance. Your doctor will know what these medications are. There's commercials on TV. Those are the two most commonly used medications, both once-a-day pills.
And Kerendia, Kerendia, is another class, but clearly approved to prevent the progression of diabetic kidney disease.
Best prescription coverage for meds. We have our access page at TCOYD if you want to talk about that, where people can get information.
Yeah, you know what, access is a tough problem, but go to our website, go to the access page. It'll give you a good head start.
Any approved drugs for kids in addition to insulin? No, except teplizumab, now to delay type 1 diabetes, is approved down to the age of 8. But no other medications for kids with type 1 diabetes aside from insulin. We still have CGM and pumps and all these kinds of things, but we generally, we're not pediatricians, but pediatricians are generally not using things like GLP-1s and SGLT2s.
And I do believe Ozempic got approved officially for teenagers and even younger than that, up down to age 12. But need to look that up to make sure I said that right.
So is insulin resistance impacted by Toujeo? I guess that could be any kind of insulin. Not necessarily. So, if you're taking, it depends on if you have type 1 or type 2, but generally with type 2, you have insulin resistance and you might require more insulin, by injection. Type 1s have insulin resistance too. The bottom line is you take the dose that you need to control your blood sugar.
Yeah, and if your glucoses are through the roof, that's called glucose toxicity. That'll make insulin resistance worse. And when you treat your glucose levels to normal, that insulin resistance caused by chronic hyperglycemia will improve.
So I think we're going to wrap it up there. So I think, some really good questions and really kind of targeting exactly the topics that we were highlighting. So when you're asking about weight and your heart and your kidneys and your blood sugars, guess what? These are things that people are working on. Like we hear that as, people that kind of walk the line between research and from patient care. It's really helpful for us to hopefully tell you guys that research is happening in the right areas. And there's a lot of advances in these very, very important and big fields of obesity, of treating the underlying cause of type 1 diabetes, of kidney disease, heart disease. I don't know if you, in the last 3 years, I feel like there's been more advances than in the last 20. It's incredible.
If any of you want to go into endocrinology and diabetes, it's a great time. I just want to say thank you for watching. Thank you for, this will be enduring on our website and diaTribe's website. We have a lot of good information on our website in our video vault. And for those of you type 1s, we can tell a lot of you are on. our one conference that's August 18th at the Paradise Point in San Diego. It's going to be awesome.
Couple of weeks, we'll see you here.
We appreciate your participation today, for sure.
So thanks to diaTribe for co-promoting this with us, putting on the forum. Thank you, Steve, for being my co-host. Thanks everybody for listening, and congrats to you for putting in the time, hearing about what's going on. We hope that this format was helpful. This actually took a lot of doing on our end to kind of put this together and bring the clips together, but I think it worked well. And hopefully you got the best of both worlds from hearing it firsthand, but also kind of our interpretation. So,
all of you missed our after party.
oh, that was awesome. Yeah, we didn't film that. So
Yeah, we destroyed the tape, actually.
All right, take care, everybody.